Good morning, everybody. Happy Friday. Welcome to yet another version of VMR. Prof. Rez may or may not join us. He's actually headed over to Europe and is in the midst of trying to sort out um, some last minute flight issues and delays. Um, but we're very, very thrilled to have everybody here. It's a little earlier than usual, so I'm so slowly but surely waking up. Gratitude in advance to Mario for scribing and Bettina for jumping in to do the teaching points. Appreciate you both. And we would like to welcome a new case presenter. Julia, do you want to unmute and tell us a little bit about yourself?
Yeah, sure. Hi, my name is Julia. I'm a third year medical student at Emory. It's good to be here and to meet everybody.
MS3 year, amazing. How's the year going?
It's going pretty well. I'm really enjoying rotations.
Uh, what are you on right now, Julia?
I'm actually on surgery.
Oh, what?
Yes.
How is it possible that you're here amidst the surgery rotation?
My team is very nice.
Oh yeah, they are. I
Yes.
mean, I think they might win the nicest surgery team award for just this gesture alone. That's really cool. So what have you done so far in terms of rotations?
I've done almost everything except for neuro. I had my IM rotation right before this, and that's when I learned about clinical problem solvers.
Oh, how'd you learn about it? Who told you?
My residents,
I
and Youssef also. He's
gotcha.
from Evergreen. I know he's very involved.
Yeah, I was sneakily suspicious that the word Yusuf would come up. Yes, Yusuf is one of our leaders and is slowly like the term CP solvers and Yusuf are slowly becoming synonymous. That's really, really cool. Do you have a sense of what you want to do, or is it too early in the process?
I'm still trying to decide.
Yeah.
I'm between IM and IR right now.
Oh, nice. Oh, that's really, really cool. I know some people with a very, very similar, similar dilemma who ultimately chose the correct answer of internal med. I'm kidding. You choose what? And what do you like to do outside of medicine?
I love to go hiking. I love reading, playing board games.
Oh, indoor and outdoor. All righty, we're crossing territories. It's really, really cool. And how did you come to learn of case presenting? Was that
Um,
learning similar to learning about CP solvers, or what? How did you know to pitch a case to us?
that was through one of my residents. He
Nice.
was telling me about these virtual morning reports. So I was like, okay, cool. And then I signed up for the listserv and here I am.
You are. That's amazing. That's so cool. We're very, very excited for your case today. Yeah, I think whenever you're ready, we'll jump right in.
Okay, perfect. So we have for today a 61-year-old man presenting to the ED with malaise, diarrhea, and headache.
Very intriguing, Julia. I love the strategy of just stopping at the chief concern. I think we can get a lot of information at that. I think that when patients show up and essentially they have symptoms referable, at least initially, to organs that are very far from each other. Here, the idea being that the patient's head hurts and the patient is having a GI issue, diarrhea. I think it sets us up for a conversation to reflect on how that might be happening, where a patient has a symptom complex referable to two distant organs. And I think fundamentally, there's one of two possibilities, is that the patient has a systemic issue involving both those organs, or that the disease is housed in one organ and the other one is a distractor. And the distractor is basically analogous to the concept of referred pain. If somebody has cholecystitis and they come into your emergency room because they have right upper quadrant pain and they have shoulder pain, the shoulder is of no significance. It's a complete distractor. And I think that's the tension here is this a systemic disease affecting directly both organs, and we can find the disease in both organs objectively, or are we being misled in some way, shape, or form? And I think the probability of a systemic disease rises whenever there are systemic symptoms. So here the malaise gives credence to the idea that there's something coursing throughout this person's body affecting their head and their GI tract. And so I think that's the thing that you would be trying to establish right now is what evidence can you accumulate for intrinsic disease in the head and the GI tract? So, for example, if the patient were to tell us that they have headache and that they have right arm weakness, the probability of an intrinsic brain issue skyrockets. If we all learn that the patient has bloody diarrhea, the probability of a GI issue skyrockets. So that's probably what I would be studying, is to try to see how much I can invest in each of these symptoms, which can inherently be referred, but also very possibly be fundamentally intrinsic to the case. And that's the first few seconds of taking care of a patient like this. In reality, the vital signs are often obtained at this time, which may not be the case in these CPS exercises. So Julia, please feel free to present accordingly. But in real life, you would probably gaze over to the vital signs to see um, and if the vital signs were abnormal, the probability of a systemic disease would rise even higher. But I will hand the mic to you, Julia, to tell us a little bit more.
Okay, great. So this patient, he presented to us about 2 months ago in the ED here in Atlanta, Georgia, just to give you guys some context. In terms of his story, 3 days ago, the patient, he was on a flight from Guinea to Atlanta. He traveled through Burkina Faso, Ethiopia, and Greece. And on the flight, he started experiencing cold and flu symptoms and feeling warm. After arriving in Atlanta, he had decreased appetite, he felt cold, and had body aches. He also had difficulty walking and felt like his balance was off. The day afterwards, he felt dizzy when walking out of the restroom. He fell and hit his head. And since then, he's had a frontal headache and also started having diarrhea and a dry cough. He does not endorse any nausea or vomiting, no respiratory distress. Nobody around him that he knows of is sick, and he's never felt sick like this before. Okay. So in terms of past medical history, he has diabetes, for which he's on metformin, and hypertension, for which he's on lisinopril. No past surgical history. His family history is significant for liver cancer in his sister. No family history of anemia or sickle cell. In terms of his social history, he was born in Guinea, but came to Atlanta when he was 25 years old. He moved back to Guinea 2 years ago to be with family, and while living there, he traveled to Sierra Leone for a week about 6 months ago and Senegal about a year ago. He lived in a village where there was livestock, but he did not have close contact with them. He did not have any pets. He thinks he might have had a tick once. Um, he drank bottled water only and sometimes ate lamb and fresh vegetables from a farmer's market.
Julia, oh my gosh, this is so fascinating. I think I learned from Yusuf that Atlanta is the largest airport in this country, and I think is a common arrival location for much international travel. And I think it's not too surprising that you're seeing what is likely an infection in a returning traveler in this symptom complex. And I think it was just very, very intriguing to hear the fact that he's having symptoms that are very compatible with infection. He's having malaise, body aches. And I think that anytime that we're dealing with an infection, we want to understand where the infection is. And if you try to figure out where this infection is, fundamentally, you'll probably get dizzy yourself. He's having respiratory symptoms, GI symptoms, head symptoms, whole body symptoms. And so I think from the get-go, the probability that this is a systemic infection is very high, owing to the vast majority of very diffuse symptoms. The only open, the only the only localizing possibility is to recognize that this may be a systemic symptom that's taking systemic disease that is causing non-specific symptoms like diarrhea or dry cough or headache, or it may be a systemic disease that has focality and has taken up shop in those organs. So does this person have pneumonia, meningoencephalitis, um, uh, and gastroenteritis, or are these just all all these just all non-specific manifestations of a systemic illness? And I think the only way we would do that is we would have to inventory each organ and try to see, are their patient's electrolytes super low, suggestive of really bad diarrhea, or does he have an abnormal neurological exam, or does he hypoxemic or have a chest X-ray infiltrate? But the probability of a systemic disease is through the roof, and that systemic disease is likely infectious in origin. And the question is open about how dominant the organ-specific manifestations are, respiratory and GI. The most alarming manifestation right now is neurologic in nature. And I think it becomes really, really important to make sure that there isn't specificity to these non-specific neurological findings. Is he dizzy because he's orthostatic, or is he dizzy because he has a spinal cord issue, or dizzy because he has a brain or brain stem issue? And I think that's the first thing that I would try to establish in this patient is, what is his oxygen and respiratory support need? How hypovolemic is he from the diarrhea? And does have any objective consequences of neurological dysfunction? That'll take immediate priority. But in the background, I think that there's a 10,000-foot view studying the possibility that this person has a systemic infection. And that whenever we're thinking about systemic infections, again, they come in two varieties. Either they are exogenous organisms, meaning organisms that don't live on the human body, that come in and go everywhere. And this happens to us all the time. I was suffering from this for 10 days with a viral infection that was affecting my whole body. There are other non-viral exogenous infections that usually have more morbidity, and these things are tick-borne diseases, endemic mycoses, mosquito-borne diseases. But the bugs that come from the outside of your body are very, very common to cause systemic symptoms. That's because our body's not used to fighting off these infections, and they get systemic very quickly. More morbidly is a endogenous infection, meaning an infection from an organism that normally lives on the human body that becomes widespread. And that's much more morbid because those infections, UTIs and pneumonias and cellulitis, are usually contained. And when they're not contained, they become disseminated in the form of bacteremia or fungemia, and the patient is critically ill. So the vital signs are going to be very, very telling here. If the vital signs are relatively underwhelming, it makes the possibility of an endogenous commensal organism much less likely. If the vital signs are very abnormal, this could easily be Staph aureus bacteremia in a patient who has diabetes, but it could also be a very, very devastating exogenous infection like malaria. So abnormal vital signs do not help us pick between a systemic infection that's coming from the world or a systemic infection that's as a result of our own body's bacteria and organisms becoming widespread. But if they are relatively underwhelming, that's when we say, oh, I wonder if this is a viral infection like COVID, because usually the patient feels miserable, but their vital signs may be not that abnormal. So the vital signs will be very, very telling here. But as we talked about, in parallel to working up the usual suspects of infection that we do all the time with an X-ray, a UA, blood cultures, this person's environmental exposure is very, very unique. And now the list of exogenous organisms that we have to think of is through the roof of all the infections that we have to think about related to all the countries he's been in and all the close quarters he's been in on the airplane, is very, very wide. So the first question that comes in these cases is, how do I make this digestible? Like, I have to think about staph, E. coli, all the usual stuff in a patient who's diabetes. And I have to think about all the possible bugs that this person is exposed to on all this travel. How do you make this digestible? And the answer is one word, two words: incubation period. This person became symptomatic very quickly upon return, which means that if this infectious process, presumed infectious process, was acquired in travel, it has to be of a short incubation period. And so if you look at our fever to returning traveler schema on the website, you can make a lot of progress by filtering the incubation between less than 3 weeks or more than 3 weeks. The incubation period here is likely less than 3 weeks, but there hypothetically, it's possible that he's been traveling for 7, 8, 9 months, and now, unluckily, he's getting an infection manifesting a delayed infection like TB, but manifesting coincidentally right now. So what's happening practically? To summarize, we need to know how bad each organ is affected. We need to know if the vital signs are markedly abnormal or relatively normal. If they're relatively normal, it would make a metastatic endogenous infection much less likely. And now, if we start to zero in on exogenous infections, looking at those with a short incubation period would probably be a priority, with a second filter of the geographic location of this patient, which we can talk about if we get there. Very, very intriguing case, Julia. I'm very excited to get more data.
Awesome. Okay, so going into his vitals, his heart rate is 111, blood pressure 107/73, respiratory rate is 20, and he's satting 98% on room air. His temperature is 37.7 Celsius or 99.9 Fahrenheit. For his physical exam, in general, he's A&O ×4, lying in bed, and no acute distress. For HE&T, he has conjunctival icterus. There is a perioral rash with blisters and slight crusting. There are no exudates in the mouth. For cardiac exam, normal rate and rhythm, no murmurs, no extra heart sounds, no peripheral edema. Home exam, his lungs were cleared to auscultation bilaterally with symmetric chest rise. And for abdominal exam, he had diffuse tenderness in all 4 quadrants. For his extremities, he moves all 4 extremities without any difficulty. And in terms of skin findings, no other rash besides the perioral rash. So going into his labs and imaging, his labs showed sodium 132, potassium 4.0, chloride 94, bicarb 21, BUN 31, creatinine 1.7, anion gap of 18, and lactic acid of 3.2. His bilirubin was 2.8, and 0.9 of that was direct. His AST was 46, ALT also 46, white blood cell 9.4, with a manual diff showing 81.6% neutrophils, 14% lymphocytes, 2.6% monocytes, 0% eosinophils, basophils, 1.8% variant lymphocytes with toxic granulation present, and polychromasia. His hemoglobin was 12.7 and platelets 73. His urine analysis showed 3 to 10 red blood cells, 3+ glucose, and otherwise normal. For imaging, his CT head showed no acute intracranial abnormality, and his EKG was unremarkable.
Prof. Rez is here, y'all. So maybe Prof. Rez, I'll just summarize for you. Julia is an MS3 at Emory who's presenting a really, really cool case of a 61-year-old gentleman who actually lives now in Guinea, previously was in the US, who's coming in with malaise, dyspnea, cough, dizziness, and diarrhea, and has an extensive travel history, which I think you can see in the bottom right corner. I'll hand the mic to you, good sir.
Julia, so nice to meet you. Is this from Grady Hospital?
Yes, it is.
Awesome. Robbie and I have been hearing about Grady because one of our mentors did their intern year there. But thank you, Robbie, for the setup. And I think, on the physical exam, a positive finding carries a high positive likelihood ratio. And here we have tachycardia and we have hyperbilirubinemia. And your mind can take scleral icterus and convert that to hyperbilirubinemia. And you might say, wait a minute, why didn't the patient complain of jaundice? Well, the bilirubin isn't that elevated. It usually has to be north of 3 to make a change in the color of skin. But nevertheless, what we need to prioritize here is that bilirubin, because that bilirubin is likely a clue to what infectious process we're dealing with. And note how I said infectious, because if you look at that CPC, toxic granulations is often a supporting marker of an infectious process. So this patient for sure is inflamed. And the clues that we have to prioritize the infection include the thrombocytopenia, the hyperbilirubinemia, the AKI with hematuria. So it seems whatever infectious process this is, and I think it's probably going to be infection, is leaving its footprint not only in the hepatobiliary system, but also in the marrow and potentially the GI tract. The one thing that we sort of glossed over, which I want to rewind and tackle, is this perioral rash. So that's like a really odd finding to be given in a CPS, and it's likely a clue. The truth is, we are limited in our ability to actually generate a DDX without seeing the red. Like, is this just some subtle crusting? Is this angry red? So depending on its appearance, that will dictate how much I incorporate that into our differential diagnosis. But nevertheless, right now my mind is kidney, hepatobiliary, possibly marrow, any returning traveler. And Robbie mentioned this in his discussion, but if you ask Charmaine, how should you approach that patient who's a returning traveler? She'll tell you to think of her great friend Seth, which means you have to take into consideration the season of year, the exposure. So a patient like this, once you see that thrombocytopenia, you have to go back to the patient and get a very detailed exposure history. T is the travel and Seth. So like, did they travel anywhere locally, et cetera? This patient has extensive travel. And then H is the host. Is this an immune compromised or immunocompetent individual? So HIV test is going to be very important. But I will say that it is possible this is not related to the travel at all, and the patient just has a common infection that is in fact locally acquired because the duration is short. It's only 3 days of these symptoms. But Robbie, maybe we can go back and forth here. You know, oftentimes I think a clue to like an unusual infection is when you, in a patient who's not severely septic, is when you see this thrombocytopenia and this hepatocellular liver abnormality. It often makes me think of tick-borne diseases and their associated cousins, like in that bucket of sort of animal-derived, zoonotic, if you will, infections. And for me, when we see hyperbilirubinemia and we see thrombocytopenia, we got to think about leptospirosis. And I feel you have to think about dengue, chikungunya, Zika. The Zika, chikungunya, they often have a rash, and dengue has this periorbital pain. I don't know all of the destinations this patient has been to, but typhoid, fever comes to consideration. So all you have to do is go to our dengue illness script, and Dan Minter had created a terrific BDX. But I would love to pass the mic to you, Robbie. I'm just thinking of organisms that have a tropism for the kidney and the hepatobiliary system that leave a footprint of thrombocytopenia and that sort of leptospirosis bucket of stuff.
Can I call you Santa? I love it. I love it. Going to Geneva in style. You know, Prof. Rez, I completely agree. I think that's the signature that my mind is picking up too. And I think, honestly, for me, that list is so large and so hard to manage that I'm wondering and just taking this opportunity to practice, like, what would I do in real life? And God, I'd probably be sending so many tests, you know? And the practical thing is to take all those things and say, well, in addition to testing, which of those infections would I be forced to think about treating right now? And what tools would I use? And I think in addition to all the testing for all, and I'd probably look up the list, Prof. Rez, honestly, like go to the CDC website. There's just so many possibilities here. So I'd want to make sure that number one, my testing is complete. And in real life, you'd probably lean on your infectious diseases colleagues. But I think the practical things that I would be doing is having a low threshold, given how septic he is and the toxic granulations, to initiate treatment with ceftriaxone for both the possibility of typhoid fever and leptospirosis, to initiate treatment with doxycycline for the possibility, as you said, that this is a tick-borne disease, and then to scrutinize the smear very, very closely for consideration of malaria, given the fact that this person has indirect hyperbilirubinemia, anemia, and thrombocytopenia. So those are the things amongst the sea of testing and considerations we'll have to do. I would really regret missing an undertreating leptospirosis from the get-go and typhoid fever from the get-go. Really regret not giving doxycycline if this turns out to be a rickettsial infection, and really regret not emphasizing the close scrutiny for deadly malaria, should that be the case. So those, I think, three things I would probably be doing with confidence, and the rest would be, as soon as I've done those things, going to the CDC travel website, looking at our schemas and being like, okay, chikungunya, like how would I be thorough about that? So that's how I think I would make it digestible, because honestly, the number of possibilities seems just so large right now. Any thoughts on that, Prof. Red?
I love it, man.
All right, Julia, tell us more, please.
Okay, I wanted to ask if there's any other specific labs that you guys would like at this point.
Yeah, Julia, I think it's a very good question. It's always excellent to ask that question. And once you develop like a hypothesis and a DDX, that will guide the labs that you obtain. So in this patient, I will for sure obtain blood cultures. I think everyone would. Additionally, this is a type of patient where you have to start thinking beyond the typical. So it's not only a peripheral blood smear, you actually have to do a thick and thin smear that will allow you to see potentially the parasites of malaria. And then for malaria, there's a rapid test, a rapid antigen, but that only detects, I believe, Plasmodium falciparum, but not the other species. So just knowing that there's limitations to these rapidly detectable tests. And then for Leptospira, you could send antibodies. Oftentimes you have to show these antibodies that are either very high IgM and some IgG, or initially it could be negative, and then later you show the convalescent antibodies. And by the way, this is assuming they have an intact immune system and the patient doesn't have HIV. Additionally, for the typhoid, it should come up on the blood cultures, but we have to be aware that PCR testing, which includes carriers testing and 16 ribosomal S, are very sensitive ways of diagnosing these exotic infections. So to summarize, I think blood cultures, I think sending the Leptospira antibodies or PCR, sending the thick and thin smear, doing a rapid test for malaria, but knowing it doesn't capture all of the species. Anything else, Robbie, that we would be sending at this juncture?
I don't think so, my friend. I think you'd probably be watching what happens to the kidney function with fluids. You might be thinking about imaging the biliary tree to make sure it's not extrahepatic. And then I think anytime you have anemia and thrombocytopenia, you have to make sure there aren't schistocytes. Um, so those are the things that I'm just making sure aren't at play, but I suspect they're probably, I probably don't think there'll be cysticytes. I think I'm interested to see if the AKI becomes a persistent part of this case. That's it that I can think of. All right, Julia, tell us more, please.
Okay, great. So his HIV test came back negative. Blood cultures did not show any growth after 4 days. His respiratory panel was negative for flu, COVID, RSV. In terms of his other advanced labs, his LDH was 295. His haptoglobin was 83. For coagulation labs, his INR was 1.6 with a PT of 18.7 and D-dimer of 7,706 and fibrinogen of 443. For his iron panel, his ferritin was 1,188. Iron total was 53 and iron binding capacity was 246. And his viral hepatitis panel showed positive Hep B core antibody, negative Hep B surface antigen, and antibody.
Professor, I'll just share some reflex thoughts and would love yours too. I think that, with the haptoglobin being elevated, being normal and the LDH not being super high, I think the case for a hemolytic process is probably weakened. I'm impressed by the degree of coagulopathy in this patient. And I think the context of thrombocytopenia and INR elevation raises the possibility of DIC, but that possibility is tempered by the fibrinogen not being low. And so I think ultimately, I don't know how much progress we made towards the answer, apart from excluding some very reasonable considerations. Could this be a regular old virus? I think in terms of using the iron studies in this context, I think that in a patient who is not, who is acutely inflamed, the value of iron studies would be to help you suspect either a granulomatous organism, which doesn't really fit with an acute illness, but it may make you think of two other kinds of organisms, a high ferritin, which is the mononucleosis organisms. So I looked and I saw that he didn't have atypical lymphocytes. He didn't have a high number of atypical lymphocytes, but he did. So that might push you to think about considering EBV and CMV, given that these salivary-borne infections are actually objectively higher in patients who travel for a variety of reasons. So monoorganisms cross my mind, and then tick-borne diseases can also evolve to a hyperferritinemic syndrome that ultimately turns into HLH. So I think helpful negatives, think about mono, think about tick-borne, and think about granuloma when you have an infectious syndrome with a high ferritin. And I think the granulomatous diseases are less likely given how hectic this disease is. So in addition to all the stuff that Prof. Rez mentioned earlier, you might expand your horizon a little bit to incorporate EBV, CMV, and reiterate the idea of a tick-borne infection. What are your thoughts, Prof. Rez?
I love that. And I wonder if the fibrinogen might be a marker of the tempo of this process, meaning that you're still dealing with DIC, but rather than it being like acute DIC, it's more like subacute to chronic, which then makes me question like how many days of symptoms did this patient actually have. And really, back to something, Robbie, you taught all of us, is that the recognition doesn't equal the onset. We always assume it's acute, but I still am favoring an infectious process with the tropism for the hepatobiliary system and the kidneys. And I would love a repeat urinalysis. And I love the idea of empirically starting treatment for typhoid fever and for leptospira and other, doxy responsive organisms. I would love to hear from Julia to see where this case takes us.
Okay, there's one last aliquot before the diagnosis. Okay, so in terms of his clinical course, he was febrile overnight to 39.4 Celsius, tachycardic to 103, blood pressure 157 over 128. And on peripheral blood smear, I'm going to share my screen. Nope. I think.
Yeah, you
I'm
should
not
be
gonna
good to go
sh-
now. Sorry about that. You should be good to go now. So.
Okay. All right. So this is what the blood smear showed.
So, Robbie, what I see here is a blood smear. I also see here is red cells. And what else I see is like within the red cells, there seems to be abnormal pigmentation, which makes me concerned for an intraerythrocytic parasite. Let me pause there for a second to see if I get the nod of approval from Robbie. Yeah, okay, we'll keep going then. And whenever you have like this which parasites have a tropism for the red blood cell? It's not many. Those include Babesia, it includes malaria, and it includes the Bacilliformis organism. But in any case, and Clostridium perfringens that we learned from Ravi and a very good NEJM. But basically, in the United States, Babesia microti is akin to malaria outside of the United States. But the thing is, Robbie, one thing that's weird about this is if this was like a hemolytic process, like that haptoglobin's pretty sensitive, and this patient's haptoglobin was normal. So let me pass the mic to you to see if you have anything else to add to this peripheral smear.
Yeah, Prof. Rez, I'm really intrigued. I think that yeah, I see those inclusions that you're pointing out, and I think it's fascinating to see that the patient doesn't have an overt hemolytic anemia. I came across an article that Moses from Cleveland Clinic tagged us in that just illustrated how hard it is to make that diagnosis of hemolytic anemia, and that every test is flawed. I learned that the maximum specificity of all the tests you can think of for hemolytic anemia is 80%. And that maximum is haptoglobin, 80 being haptoglobin being low is 80% specific and about 80% sensitive. So about 20% of cases will have a normal haptoglobin. And that article was really, really cool because it just showcased how diagnosing hemolytic anemia often requires painting the whole picture and accepting holes in it. And so right now, I think that it would probably be a working diagnosis of a intraparasitic infection because I think I would be more confident if the patient had overt hemolysis. So I think there's two possibilities. Either this person has one of those four infections that you mentioned, and their hemolysis might become more overt very soon, similar to what you just said about the fibrinogen, or that we're completely being faked out by the smear and there's nothing wrong with it. Those are my reflex thoughts, but I think it just goes to show how in a patient with a fever and a returning traveler, there are three life-saving things: ceftriaxone for Salmonella leptospirosis, doxycycline for rickettsia, and smear, thick and thin. Those are the things that are actually going to save the patient's life. Many other things could kill a patient, but there's not much you can do about them, like dengue. So that third thing on that checklist is either real or it is completely misleading us. I don't have the expertise to tell, but that's what I'm thinking. Where are you at?
Oh, I was just trying to like physiologically explain why haptoglobin might not be low. Is because haptoglobin, it becomes low in hemolysis because hemoglobin binds with haptoglobin. But if you have extravascular hemolysis, like in the reticuloendothelial system, hepatosplen, and it's low grade, I can imagine it like the hemoglobin never reaching the circulation to bring. I was just trying to explain why it's not as sensitive as one might imagine if it's low grade. But at the same time, I will mention this: there's many times I look at a smear and I think there's something wrong because we're trying to find it, but it's just an artifact. So Julia, what is the final read on the smear?
Okay, the final read on the smear was malaria. So if I zoom in a little bit, there was like a parasite in one of the erythrocytes on the left side panel, which I think somebody pointed out in the chat.
That dot, huh, Julia? And that red, the little blue dot. Yes.
Eagle eye, Prof. Rez, eagle eye. So Julia, what happened? Oh, I think you're muted, Julia. Sorry.
Oh, sorry. Yeah, so he was diagnosed with malaria with Plasmodium falciparum. And he started on a 3-day course of atovaquone progranulol, and he improved after that, and he was following with ID outpatient. Yeah, I also have some
Julia, yeah.
points if
Oh,
you guys
please.
Okay, so I was looking at I never thought that I would see malaria in my medical education, so this was a very interesting case for me. And so I was looking up the rate of Plasmodium falciparum in the US, and apparently the average number of cases of malaria in the US has steadily increased. And there's about 2,000 malaria cases reported in the US each year. The vast majority of these, 98.8%, are imported. So travelers from an endemic region, like our case today. There continues to be a risk of local transmissions, which is why the CDC is monitoring for it very closely. I thought it was interesting that there's also a climate change component to this, with increased risk of vector-borne diseases in the US. And the Intergovernmental Panel on Climate Change predicts that by 2050, malaria may threaten some previously unexposed areas worldwide and cause a 50% increase in probability of malaria cases. I also thought it was interesting looking at blood smears as a gold standard for diagnosing malaria, because some patients may actually become symptomatic before the parasites can be seen on blood smear. And so a single negative blood smear does not rule out malaria. And blood smears should be repeated 3 times, one every 12 to 24 hours before ruling out the diagnosis.
Dude, that was awesome. That was so cool. I'm just curious, just to reflect on a couple of other things, and then zeroing on what you just said. Did you learn anything about the rash? That's something that was a complete knowledge gap for me. What did your team talk about? Was it true, and unrelated, or what connection did you make of that?
So the patient has had a similar rash before when
Mm.
he's been sick before.
Yeah,
So I think it's just because of immunocompromised state, and probably herpes is what we
yeah.
came to. Yeah.
Reactivation maybe. Gosh, that must have really been a tricky to try to like deal with in the moment. I'm curious if you could shed light on how you went from how you guys went from smeared. How did you identify that it was falciparum? Was it the folks had expertise visualizing it, or was there more nuanced testing, or how did you go from malaria to falciparum?
Yeah, so the falciparum is from the rapid antigen test.
Mm.
I think it also picked up potentially other species as well. And I think we're also waiting on a thick smear, which confirmed that it was falciparum.
Awesome. Awesome. How did the patient do?
He did really well. He like improved. He was feeling better after starting his medications, and then he was discharged.
Amazing. I really learned this really interesting thing that I'd love to share with you, which is that um, I was like this too. When travelers go back it makes a difference if you're a returning traveler who has a residence in a foreign country, or you're a returning traveler who is temporarily traveling. And I was going back and forth to my home country for a long time, and I learned that it's patients like myself who are much more likely to get infectious diseases for 2 reasons. The first is that we're very unlikely to take prophylaxis. I never took any prophylaxis going back home because of the illusion of immunity, but also because of the high chances of exposure and indulging in the quote unquote normal life of that community. So typically travelers who are temporarily staying are more likely to take prophylactic medications and to not completely embed themselves in the community. And so when I would go back, I would not take any prophylaxis, and I would pretend like I've never left before. And the reason that's a problem is that for many of these infections, you get low-grade immunity from low-grade exposure all the time. So residents in areas that are endemic to malaria are much less likely to get acute malaria as an adult because for their entire life, they've been exposed to the organism and have had developed immunity. But when you leave for 10 years and come back and live the normal life that you used to live, you no longer have that protective immunity, and now you're vulnerable to getting acute disease. So I bet you that if he had never come to the US and had always been in Guinea and stayed in Guinea, he probably wouldn't have had this happen to him more acutely. But the fact that he came here for so long, lost his immunity, and then went back, exposed him to malaria again. So I think there's all these cool variables that help you predict what a patient with a fever and a returning traveler, what the incubation period is, and whatnot. But there's all these like nuances that you learn from experts, and I learned this from Dr. Natasha Spottiswoode on a VMR last year. I think it was a really cool program. What are your thoughts, Prof. Red?
On that, I was laughing at the story you shared, how you didn't follow the protocol.
Not at
So
all.
that's my thoughts. Otherwise, Mike, to our lovely teacher, Bettina.
Hi, everyone. Thank you for such an amazing case. So here are our teaching points for today. So the first main teaching point is that when symptoms refer to distant organs, the big question is to determine if there is a systemic process that involves both organs or if one of them might be a distractor. And in this case, identifying how bad each organ is affected will be crucial to understanding what the infectious process is. So for example, in our case, the patient had hyperbilirubinemia, AKI, and thrombocytopenia, which were clues to what infectious process is happening with tropism to the marrow, kidney, and the hepatobiliary system. So the second main teaching point is that we did talk about exogenous versus endogenous infections, and understanding the vital signs are very important. Specifically, if the vital signs are underwhelming, this makes a metastatic endogenous infection less likely. The third is to also understand the incubation period. So in a patient who becomes symptomatic quickly upon return, it can be either something that they acquired with travel or even locally acquired with a very short incubation period. And then given the septic presentation of our patient, there should be a low threshold to initiate treatment with ceftriaxone for possible typhoid and leptospirosis, doxycycline for tick-borne diseases, and scrutinizing the smears. And then just some clinical pearls for recall, in patients with high ferritin, you can think of EBV, CMV, tick-borne diseases, and granulomatous diseases. And then for abnormal pigmentation in RBCs, you can think of intra-erythrocytic parasites like Babesia, malaria, perfringens, and bacilliformis. And then talking about malaria, which is our diagnosis. So a single negative smear does not rule out malaria, so it must be repeated 3 times before ruling it out. And then residents who are in endemic places are less likely to get acute malaria because they have that protective immunity versus those who are returning after a long, long time and have lost that immunity. So those are the teaching points for today.
Oh, I love the way you organize that, Bettina. The highlights and then the pearls. That was so cool. I think that's the first time I've heard it that way. Amazing job. Julia, I really, really hope you'll strongly consider internal medicine. That presentation was so smooth, so polished, and had all the details we need to get to the bottom of it. And your teaching points at the end were just top notch. So thank you so much for putting it together. And I hope this will be the first of many that we see you here on VMR for. Oh, and a shout out to Mario for epic scribing. A lot of detail here. Thank you, Mario. Alrighty. I think Prof. Rez is making his flight. I hope safe travels, my friend. And happy Friday for the rest of you. And I hope you enjoy your. Yes, there he is. Bye, Santa. Travel safe. All right, y'all. Hope to see you tomorrow. Bye.